السلام عليكم ورحمة الله وبركاته. شهر مبارك إن شاء الله على الجميع. Good afternoon, ladies and gentlemen. Ramadan Kareem for all of you. Today we have Dr. Hadil Tanashat. She is senior registrar in medical department. She had her board in 2020, and she worked after that in Jordanian Minister of Health. Then she joined us. Today she will talk about a really important topic, I guess, for the key cash, because we, in the Department of Medicine, we get a lot of questions about it during the daily practice. I hope she will shed really a lot of information about this topic. Please, Dr. Hadil.
السلام عليكم ورمضان كريم مرة تانية. Today we're gonna talk about biological agent, and we're gonna emphasis on biological agent we used in KCASH. Actually, Dr. Abu Asrar start to talk about this subject. We will continue. هلا regarding biological agent, the first thing that cross your mind that we are talking about infliximab, Humira, and that's drugs. Actually, there is a wide range of medications that's named under biological agent. The first generation of biological agent that we may forget is the vaccine, the blood product, and the stem cell injection. And the second generation of biological agent, the drug that we all know and we all deal with. The issue about biological agent and the revolution that is made and how expensive it is, it's all related about the manufacturing of biological agent. It actually not a simple chemical reaction and not a simple predictable reaction. How to make a biological agent? A piece of DNA is inserted into a living cell. Usually could be a yeast, a viral, a mammalian cell. This introduction of the DNA piece will produce a large amount of a protein. After that, we gonna harvest that protein and use it as an ingredient of biological drug. So that's why it's expensive. It's not a chemical reaction. And finally, we have the medication. This slide have an idea about how the DNA is inserted in a mammalian cell, and then we have to remove all the cell part and keep only the protein that we need and make it a part of a new drug or a new medication. After we say briefly about, or after we talk briefly about the production of biological agents, how do we imagine the biological agent? It is a small molecule, nanoparticles, or large molecule? Anyone have an idea? Biological agent actually is a very large molecule. Okay. This slide will help us to imagine the difference between the regular drug or small drugs like aspirin and the size of the atoms in it, the large molecule drug, and the large biological drug, which is a complicated medication. Even to simplify the idea, they compare it with the complexity and the cost, like the small drug molecule with a simple bike and the large biological molecule with a business jet. Just to make the idea easy, how complex and how expensive is this medication. This slide just to notify if someone didn't know the information that the name of the biological agent may guide us to the category of the medication or the vector that used to treat it. Like if we look to the map, it's mentioned that this drug is monoclonal antibodies, and all the suffix is used to indicate something regarding the medicine used. The type of biological agent, it's a variety of medication. Some resources mention it's now almost 7 types of medication. We will mention the 4-1, tumor necrosis factor, alpha inhibitor, beta cell inhibitor, interleukin inhibitors, and selective co-stimulation modulator. We will not mention all of them. We will emphasize on 3 drugs that we deal as internal medicine department as consultation or even in the floor with the patient of them. We see all of them. We try to find answers to some question we have. To understand the anti-tumor necrosis factor, we will talk briefly about tumor necrosis factor A. I think Dr. Abu Asrar mentioned that it's actually a signaling protein involved in the acute phase reaction and systemic inflammation. It's produced by macrophage, CD4, lymphocyte, natural kill cell, and neutrophil. So the idea, once you stop the tumor necrosis factor alpha, the inflammatory cascade will stop and the disease will be improved. That's the idea of anti-tumor necrosis factor. You will stop the inflammation process and the disease improved. The first thing we will deal with is infliximab. Infliximab have a two-part, human IgG part and a cabalite chain. It's a soluble and cell-bound TNFA. It does not bound to TNFB. Its half-life 8 to 10 days. You will find with most of the monoclonal antibodies this information that concomitant use of methotrexate will improve the presence of a monoclonal antibody by 30%. It have multiple explanation. Some of them say that methotrexate reduced the antigenicity of the monoclonal antibodies, and some studies say that it reduced the clearance. For always use methotrexate with infliximab, even we will have the same information with the Humira, will improve the exposure by 30%. Before describe the infliximab, the indication it's up to our mention with you in the ophthalmology. We'll talk about our part. We didn't use or we didn't need renal or hepatic adjustment of the dose. The only adjustment is needed with the patient who have an advanced heart failure, like NIHA classification class 3 or class 4. He need to keep the dose less or equal to 5 milligram per kg. Then the first thing we will talk about no renal or hepatic adjustment for the dose. Is there a cases contraindicated to use infliximab? The first one that we mentioned, advanced heart failure stage, the patient with a previous hypersensitivity reaction to infliximab, current severe infection or active infection. Use with caution, as Dr. Abu Asrar mentioned, we will use on caution with pre-exciting demyelinating disease, the patient of MS, mild to moderate heart failure, history of seizure, patient over 65 as they are more prominent for infection and malignancy, uncontrolled DM, and moderate to severe COPD. Something to mention, infliximab is contraindicated in patients who will take live vaccine, okay? Live vaccine should be 4 weeks before the immunosuppressant or 3 months after. In some cases that we have to give or the patient have to take live vaccine like MMR and smallpox. Then we decide, we know when to give, and the contraindicated, the caution situation, how to prepare our patient for infliximab. The first thing that all of us know is the tuberculosis screening. Tuberculosis screening done firstly by a history of exposure to TB or history of be affected by a TB patient, be a TB patient or exposure to patient who have a TB. The second step will be one of the following: to have a negative BBD test or a negative purified interferon gamma release assay test. Firstly, you have to assess your patient by a history, if you have infected with TB before or you have exposure to TB patient before. The second step to do one of them, either BBD test or negative interferon gamma test. If the patient have negative all of them, you can proceed. If you have latent TB, what we mentioned as to have one of the tests is positive and X-ray is free, the patient with no symptoms, you have to start the patient on isoniazid for 9 months, at least to be 4 weeks before the dose of immunosuppressive. You diagnose your patient with latent TB to start isoniazid, at least 4 weeks, then you can introduce your immunosuppressive. If the patient was a case of active TB, he have to be referred to infectious disease consultation and to be fully treated with that. This is regarding TB. I hope it is clear. Regarding hepatitis B, the patient at least should have hepatitis surface antigen negative. Regarding the heart failure, we mentioned you have a serial echo, especially if the patient, the baseline of the patient, he is a heart failure patient, you have to follow up. The other history or the other assessment to look for any chronic infection, any sign of a chronic infection like weight loss, sweating, anything like that. The side effect of anti-TNF, we will find this some common between the infliximab and the Humira. The first thing is injection site and infusion reaction. It happens on 40% of patients, lasting 3 to 5 days, almost like a bee sting pain. It can be treated with topical steroid or topical antihistamine and to rotate the injection site. Sometimes it's from the preservative additive to the infliximab. Usually this reaction will stop 3 months after continued use. And if it's continue, you can use other type of it. Regarding the infusion reaction, it occurs with less than 6% of the patient. It's almost like a headache, nausea, and dyspnea. You can stop the infliximab and restart it with a slower rate. And if your patient have 3 drug allergy, not including the infliximab, or you give the first dose of infliximab and he developed infusion reaction, you can pre-medicate him for the next time to give antihistamine and to give aspirin better than acetaminophen. To summarize, the injection site reaction, it's common, almost more than 40%. Bee sting appearance around the injection site, antihistamine and steroid typically rotate the injection site. The infusion reaction, while you are giving the infusion, he feel headache, nausea, dyspnea. You don't have to pre-medicate all of the patient unless your patient have multiple drug reactions or multiple drug allergies, or he have infusion reaction before that. Serious bacterial infection, it's a common side effect with all of the immunosuppressive, occur in 3 to 4% of all the patients taking or immunosuppressive or the DMARD. One of the serious infection, it's pneumonia, occur with the first 6 months of the treatment, of starting the treatment. Once your patient have a febrile infection, you have to hold the immunosuppressive unless the cause of febrile illness is a common cold. If your patient have a simple common cold, you can proceed. Until that, unless you have to hold the immunosuppressive. Regarding the patient who have an open wound, once he has an open wound and you start infliximab, the patient is risky to get cellulitis. So the better to have the wound healed, then we have to introduce infliximab. Patient with a chronic infection like osteomyelitis and bronchiectasis with recurrent pneumonia is not advised to be on infliximab. Regarding the opportunistic infection, اللي هو reactive TB, this is why we screening them for tuberculosis infection, because the tumor necrosis factor is something essential for the granuloma formation. So once we suppress them, the patient and the disease will be reactivated. The interesting thing is more than 50% of the reactivation of the TB will be lymph node reactivation, not lung reactivation. Regarding pregnancy and lactation, we will have a detailed slide at last, but it's almost category B. Category B in the old classification, يعني if the maternal condition is recommended to take infliximab, you can give them. This is all about infliximab. We will start adult Humira or adalimumab. It's also a fully human IgG monoclonal antibodies bind to the soluble and transmembrane form of tumor necrosis factor A. The half-life of it's 10 to 13 days. The same as infliximab, adding methotrexate will increase the patient exposure to additional 30%. Also, the risk factor and the side effect will be common with the infliximab. We will highlight some issues. The patient will be in the risk of severe infection as he will be a risk of invasive infection as histoplasmosis, listeriosis, pulmonary aspergillosis. The patient will be risk of development of antibodies to adalimumab. He will have elevated CK and transaminase. He will have lupus-like syndrome, lymphoma, pancytopenia, alopecia areata, and alopecia universalis. After talking to the adverse effect we are expecting, we will say about the monitoring. We will monitor the patient with CBC, urea, and liver function tests basally, then monthly until the first 3 months. Then after that, the patient is stable every 3 months. And regarding the lupus-induced drug-induced lupus, the patient will have an annually anti-double-stranded disease. He will have annual serial of echo even, and we will notice the patient by history to looking for any malignancy sign or to have skin examination. Regarding toxicity of a Humira or adalimumab, it's almost a safe drug. There is no significant toxicity. Some patient, and regarding pregnancy and lactation, it's category B. Some patient develop autoimmune hepatitis after adalimumab or Humira, and on the study, it wasn't enough to stop Humira to the patient to be improved, okay? They have to be treated with steroid, and the steroid have to be adjusted accordingly. So if patient on a Humira develop autoimmune hepatitis, it's not enough to stop Humira. It have to be stopped, and patient have to be referred and started on a steroid. The third drug that we start to use with recently in our hospital is one of the anti-interleukin 6 drug اللي هو tocilizumab. Tocilizumab is a humanized IgG monoclonal antibody that bind to the soluble and membrane bound of interleukin 6 cell. The different about tocilizumab that using it with methotrexate will not help the patient or increase the exposure of the drug. The most important thing to screen when you're starting tocilizumab is CBC and liver function test and liver profile. هلا is basically the absolute neutrophil count less than 2000 or AST ALT more than 1.5. You cannot. It's advised not to start the medication. And if it is you start the medication and the ALT and AST was more than 500 أو 5 أضعاف, and the ANC was less than 500, platelet less than 50,000, you have to stop the medication. So before starting tocilizumab, you have to do CBC and liver function test, CBC with differential actually, and liver function test. According to the number, you are advised to start the medication or even when to stop it. هلا monitoring, as we said, we do it with the CBC and liver function monthly until we have a stable dose, then every 1 to 2 months. Lipid profile also every 1 to 2 months until stable dose, then every 3 to 6 months. هلا the adverse action I mentioned in the previous slide. You will have neutropenia and you will have thrombocytopenia. هلا neutropenia less than 500, you have to stop the medication at all. From 500 to 1000, you can hold the medication and restart at lower dose. Regarding thrombocytopenia, the same. هلا the patient may have the risk of GI perforation, especially the patient who taking NSAID and steroid with the tocilizumab, because it has a main role in the fibrotech healing and repair of the cell. So when you are using tocilizumab with NSAID and steroid, you are prone your patient to more risk of perforated GI complication. The last side effect we will talk in this slide is macrophage activation syndrome. It's happening mostly with the patient with juvenile rheumatoid arthritis and patient with rheumatoid arthritis. They will come with fever and picture of any bad and worse infection. Adalimumab have no increased risk in malignancies or congestive heart failure notice. It have multiple drug interaction. It's advised to check the medication of the patient with it before started it. Especially birth control pill, atorvastatin, simvastatin, and omeprazole. Then we talk about the biological agent. We mentioned 3 of them that is used in our hospital. Now we will talk about a new terminology that appear and is used widely now, and we have actually some drugs here. It is biosimilar. From its name, it's biosimilar. It's similar to the biological medication that's used. It have the same efficacy, the same side effect, and the same immunogenicity with much lesser price. It have been used widely and have a good effect, and with the same side effect as we mentioned. The cause that it's much cheaper, it's all about the manufacturing. The manufacturing that make the biological agent is very expensive, and the biosimilar it was cheaper by 80% almost. We will mention something briefly about biological agent in pregnancy and lactation. We say some of them is considered category B, which we can use if the case of the patient is indicated. The category B is mainly monoclonal antibodies. The other agent is considered category C or classification C. That means that there's no enough study in human or animals about this use. Regarding lactation, most of the monoclonal antibodies that reach the baby will be digested in the digestive system. The only issue that if the mother taking monoclonal antibody or immunosuppressive agent, you have to postpone the live attenuated vaccine of the baby to at least 6 months from the dose. And that's all. Hopefully that it was short and useful. Thank you for your listening. Any question? It seems no question, no comment.
Dr. Sliman.
Thank you, Dr. for the good review. So I have one question regarding the use of methotrexate with the anti-TNF medications. Is it only methotrexate or also other anti-metabolites like Silcept would increase the exposure of
Actually, it mentioned by name in the literature. Yes. Even in UpToDate, it mentioned by name, methotrexate only. There's no mention for other anti-metabolite drugs.
Okay. So one thing about infliximab and how to address allergic reactions, there is some literature that suggests using a methylprednisolone in patients who have severe reaction, that pre-treatment with methylprednisolone, IV, then in between the doses of the IV methylprednisolone, infliximab is given. This is for patients who develop a severe reaction. I don't know if you have any experience with this regimen, trying to avoid the severe reaction.
Actually, it's according what do you mean by severe reaction? If you mean something like anaphylaxis, patient need monitoring, he's become unstable, I think we cannot reintroduce infliximab for patient with anaphylaxis. It will be forbidden for life. The thing that we mentioned for the pre-medication only, if the patient have already a history of multi-drug allergy other than infliximab and he have infusion reaction like some headache, dyspnea, we can pre-medicate the patient, mentioned in literature, by aspirin and some kind of antihistamine. I think Norul for steroid, and if you know steroid need time to start working. I didn't hear anything about to give IV methyl between the doses. I will check the literature. I can contact you if you need it.
Thank you, Dr. Sliman, for this good question, actually. Yeah, but in all manufacturers, they say if there is hypersensitivity or allergic to the drug, it should be absolute contraindicated. Some people, they try this method by giving IV methylprednisolone or antihistamine, but it's really very risky and need high specialized center for that.
Thank you for your time.
One more. So one more comment about the biosimilars.
Yeah.
So we have now the adalimumab biosimilar in the hospital, and I remember that we had infliximab biosimilar before, then was removed because
they didn't mention this time to me.
Yeah, it was not as effective, and I see the same thing with the Hyrimoz or biosimilar of adalimumab of Humira, and it is not as effective. I had several patients who were on Humira and were controlled, and now with the biosimilar, it is not as effective.
We see them; they shifted back to infliximab, right?
Yes,
we deal with them.
Yes, so I'm not sure that they are as effective, and the price that it is 80% of the original price. It is
Yeah.
not. It is not discounted 80%. So it is
No.
only 20% discount. I don't see a huge value with this. To be honest.
It could be. It's you at final you're dealing with the patient directly. You better judgment regarding the effect of the drug, but that's what was mentioned in the literature. Maybe it has something with يعني تجارة وتسويق بالأخير. They write even in up to date they have the same effect, the same side effect with less price. It's all about the price they are thinking. Thank you.